Welcome to our State of the Technology presentation on manual defibrillation and pacing. Joining us here to share his expertise and insights is Dr. Vince Mosesso. Dr. Mosesso was the founder and medical director of the National Center for Early Defibrillation, which is now the Sudden Cardiac Arrest Association. He's a professor in the Department of Emergency Medicine at the University of Pittsburgh School of Medicine, medical director for pre-hospital care services at the University of Pittsburgh Medical Center Health System, and also serves as the associate medical director of the City of Pittsburgh EMS system. Welcome to the conference, Dr. Mosesso.
Thank you, Mick. It's great to be here. Thank you for having me here to speak about manual defibrillators and monitors for EMS.
So, manual defibrillators with pacing capabilities are obviously major purchases. So, EMS decision makers need to have good information to support a well-informed decision when considering their options. So, what insights can you share about what EMS agencies should be looking for when considering these types of purchases?
Mick, as you know, these devices have really become much more sophisticated, but also much more expensive than they were when you and I started using them a few years ago.
Yeah, more than a few years ago.
Yes. But I think some of the basic characteristics that we looked at back then even still apply. One of them would be the portability, referring to the weight and size. How easy is it to, maybe put on your stretcher, mount in your truck, that sort of thing. And the other one is really durability. In EMS, we love to bang things around, and unfortunately, occasionally things fall onto the ground. We once had one of our defibrillators actually run over by a fire truck that was on scene, and it kept on ticking. So they do test these devices for environmental testing, things like dust, water. There's an IP rating. The higher, the better. And then there's also for durability and standing up to that, we talked about dropping it, is literally called a drop test. And they drop it from a certain amount of feet to see if it remains intact and if it will still function. So those are kind of like some really basic things that you want to look at and make sure the device is designed for pre-hospital use, certainly. So another really important factor in my mind, perhaps most important, is the user interface, or what I like to call knobology. And what I found sometimes in the past is it was actually not very empiric to figure out how to, say, move from one function or one screen to another. And the way you did that maybe was a little bit cumbersome. And I think that's really important. We have to realize we're working in a kind of time critical situation, but also very intense. So we're in a very high intense impact. We may not be able to think as clearly, or we want to react more. So having it very easy and empiric on how to use these devices, I think, is really critical. And I do think manufacturers are taking more stock of that now and really trying to improve that aspect of these devices. I know they'll have like some sessions, where they ask users to look at it and get feedback on that. So look at that, see how that fits in your system, perhaps even what folks are used to or what they feel most comfortable with. So that is really one really critical factor, I would say. And then look at other aspects of it too, like how easy is it to acquire and transmit an EKG? What about different lighting conditions? Can you still see the screen? How easy is it to do things like synchronized cardioversion and pacing? All of those things. Look at those specific factors, because those are all time critical functions that you want to be able to do without, having to try to look up in a manual or ask someone else. So that's a really important part of it. Another aspect you should look at, especially as IT continues to grow and we're using almost always, electronic medical records now, is how is data captured? How easy is it to enter data you want to put in a data point? And how easy is it to transmit that data, and especially EKGs? You may need to transmit that to a hospital, to a command center. And subsequently, you want to be able to have all that information in a file and easy to review, easy to perform QA on it. So look at all those factors, how it's stored, what's the expense of that, what's the reliability of those systems. Another factor is many of these devices now are becoming multi-parameter monitors. And so a lot of them will have non-invasive blood pressure capability, capnography, pulse oximetry. I think those are becoming fairly standard. But now some can do carbon monoxide, methemoglobin. I think there's one even that does hemoglobin level. And you can do invasive blood pressure monitoring potentially. So I think what you have to look at is what's important for your situation. If you do some critical care transports or transfers, then that invasive blood pressure monitoring might be important for you. But if you never do that, then that may be an extra expense that is not needed. So consider, what situation you're in and when you might need those other parameters. Another aspect would be is how does this device fit in your system and who all would use them? Would there ever be, say, a basic level person using the device, in which case you would probably want that AED mode where it can do the cell analysis of the rhythm. And then along that lines, think about how do you interface with other responders, and is it possible to coordinate it so that you all perhaps have, say, the same brand of equipment, or at least so that cables and pads are interchangeable, because that could certainly reduce costs in the system, but also that patient turnover and transfer from one unit to another would be facilitated as well. And then perhaps a whole different aspect of this is what is the maintenance required? How are the batteries charged? Where can you charge them? What kind of support does the manufacturer provide? How long is that support provided? What is the cost? Is there regular maintenance required? Do they provide that? And maybe kind of check on what is the reputation for the responsiveness for service. How important is that to the company? That if your monitor defibrillator goes down, how quickly can you get, say, a loaner device and get that one repaired and back to you? So those are all things that you might not think about up front, but really affect you whenever you're actually using the device. And then the last thing is there are some really new things coming out, like some may have a built-in camera. Some now have ports for ultrasound or video laryngoscopy. And so again, I think you want to look at, do these have any application to your system? Would you utilize that? Can you see maybe in the near future that's something you might be utilizing? Then you might want to think about those things to be prepared and have the capability to move in that direction.
No, that all makes a lot of sense, Dr. Mosesso. But as I'm sure you can appreciate, having the right technology is just part of the equation when you're trying to optimize care. You've also got to properly implement it. So what are some best practices in use of manual defibrillation and pacing that EMS decision makers should kind of factor in when considering their purchasing decisions?
Well, Mick, that's an excellent point. And I think we would both agree that it's really important that we use the technology to facilitate providing excellent patient care and not having the technology kind of drive us as to what we're doing and how we're providing care. One perhaps example of that would be high performance CPR. We know what we want to do as far as continuous chest compressions at the right rate and the right depth. And how does this device help facilitate that in a user-friendly way? Some devices will give us feedback on that in various ways, but think about how that feedback is provided. It often can be visual and or audible. And some providers have had concerns about the audible feedback only because family members or others on the scene may be hearing, this feedback information that might sound critical of their performance and not really understand the context of that. So just something to think about if there's options there available for that. I think most of the time you can turn the audible portion off. And then again, what about the user interface? Are we able to quickly get to those critical functions like defibrillation, synchronized cardioversion, and pacing? And are they easy to set up and activate? So those are things that I think would really be important for that, being able to implement the technology as best as possible. And then another consideration would be, some of these devices will have alarms. We can't always be looking at the screen every second. You might be starting another IV, you might be looking something up or just talking to the patient if he's awake. So there are some devices that will, alert you if there is a change in vital signs or a change in rhythm, so especially onset of, say, VFib, which hopefully you would see clinically too. But these alarms can be very helpful just so that you can respond immediately to that situation. And then think about, what is the cost and the capability of carrying other supplies and backup supplies. You may need like pediatric pads. You want spare batteries. You want, spare adult pads. You may want to have a backup therapy cable and a monitoring cable. So how does that all work, and what's the reasonableness of getting that and putting that in a package with the defibrillator?
Sure, sure. So another point that I'd like you to address, Dr. Mosesso, is technology and its implementation doesn't always go smoothly. So what are some common mistakes or pitfalls that EMS decision makers should be aware of and take steps to prevent or avoid when choosing manual defibrillation and pacing technology?
Yeah, Mick, that's a great point. I know when we have our electronic medical record system updated, it always seems like there's some glitches. We have more user errors, and it's just challenging anytime you have a change. And so particularly important when, you're having a major equipment change or updated equipment. So you want to make sure that goes as smoothly as possible. I think the first thing should be is that end users should be part of the process and should be involved in trialing these devices in the field, getting experience using them, comparing devices, and getting some feedback on that. And then hopefully those end users will also be more enthusiastic about accepting the ultimate decision. Now, remember, this trial period should not just look at the function of the device itself, say on scene, but also look at its interoperability, such as data transmission, synchronizing with your system, but also with your medical command system and with receiving hospitals. And how does that look as far as transmitting EKGs, transmitting EMR reports for their records? And some places may want to utilize real-time visualization of your monitor screen, which is also an unfolding capability now. And then once a decision is made on what device you're going to get, certainly you want to let everyone know in advance as much as possible, provide them with as much information as you can, and then you want to have practical training sessions on the device. Don't just throw it out there and expect them to kind of look at it, before their shift at the station. You never know how much that will work, and they will not maybe understand all the components. So have someone who's particularly trained in the device go through it in a practical manner, make sure that all the users know how to do all the functions that are pertinent to them. And then also think about other responders that might have some interface with this, that might have some need to know about it? Do you have other responders, transport services, or first responders that typically might help you do things on scene? So you want them to at least understand some basics about the product and what they might be able to do to help you on scene.
All makes a lot of sense. And then, kind of as we wrap this up, research and innovation can have a dramatic impact on, what we select and how we implement it. And the funny thing is, these research advances and innovations don't happen on a set schedule. So it's a factor for the EMS decision maker, because if they know that the next new thing is just around the corner, a new version of defibrillator is going to be coming out soon, etc., that might give that decision maker pause to maybe pump the brakes a little bit on the decision and wait until the new version of whatever it is comes out onto the market. And, there's also research implications as well. So things like double sequential defibrillation or whatever that's a little bit more out on the cutting edge of things may also factor into decision-making process. So given that aspect, are there any research developments or innovations related to manual defibrillation and pacing that decision makers should be aware of?
Well, Mick, there are, the manufacturers obviously are always trying to figure out how to best enhance the device. What is the next new capability that will be, beneficial? And there are some studies I actually looked in clinicaltrials.gov to look up any new trials coming out. And perhaps one of the ones, and this is actually available to some degree, I believe, but there's continuing work looking at analyzing the ECG rhythm. Well, first displaying the ECG rhythm without the artifact of chest compressions. And then for the automated mode, being able to analyze that rhythm even during chest compressions, which obviously, if you could alert, okay, we have VFib, we know it's there, you can do that analysis while chest compressions are ongoing. You can decrease that delay time of no compressions before shock. And there has been research that shows that really does impact the conversion rate and the survival rate. So we know decreasing those pre-shock pauses is very important. So that's a new and unfolding technology that is currently under study and available to some degree. Another one is ST segment monitoring, and that also is available, but also undergoing further research and determining, if you can pick up, if you have a sudden change. We know we often ask EMS providers to do a second or third ECG, and you might pick up ST elevation on the second ECG that really wasn't apparent on the first one. So this technology would try to pick that up and say, oops, looks like we are now having some ST elevation. You might want to do another 12 lead and confirm that. So that could be very helpful. Again, time is muscle when it comes to heart attacks with STEMIs. And so again, that would be a very useful capability. You mentioned double sequential defibrillation, and there has been really very little research on that, but it has not yet been shown to really improve survival. But I think there is a theoretical basis to it, and we know that sometimes that's done in the electrophysiology lab. What would be important there, though, is to realize that it's currently not considered a standard part of ACLS under AHA guidelines. And also, you need to talk to your manufacturer about how that would affect the device and how that affects the warranty, because it could potentially send a signal, high energy signal into the device. And so there's some variability on how that might affect the device. So just something to think about there. But I think we'll see more research coming out on that over the next few years, and hopefully provide some clarity on maybe, how does it help in cardiac arrest, and what's the best way to actually do it. And then there are some things that are already on the monitor that we're learning how to use in more circumstances. And for instance, one thing is some recent studies came out showing the severe hazard of hyperventilation in patients with traumatic brain injury. And these devices can monitor carbon dioxide levels, and tidal CO2 through capnography. And so rather than just using the capnography to say, we know the tube's in place, you can use it to say we're maintaining the proper ventilation, proper minute ventilation, that we're not inappropriately or unknowingly hyperventilating these people. And we know that really causes severe secondary brain injury. And that even can extend to patients who are post-cardiac arrest. We do not want to decrease their brain, cerebral blood flow either. So watching that end tidal CO2, although it doesn't always exactly correlate with, venous PCO2, it can still help us a lot in most cases and guide us in the right direction so that we can help avoid that inappropriate hyperventilation.
Well, is there anything else you think that buyers of manual defibrillation and pacing technologies should be aware of, or that we haven't covered, or anything you want to re-emphasize to EMS decision makers as they contemplate that purchasing decision?
Well, Mick, you mentioned earlier in the last question about, is your device, is there a new device going to come out? Is there a new model coming out? So you may want to consider where that device is in its lifespan, if you will. Was this a new device that just came on the market, a new model that just came on the market? And if so, there you want to maybe have extra diligence in finding out if all the technology does work. Are they having any problems with the device? Get some feedback on that aspect, really make sure the warranty is robust. And then on the other hand, if you have a device that's been out there for a model that's been out there for 5, 10 years, say, or more, try to get some idea from the manufacturers. How long is that model going to be, on the market, and how long will they support it after it's no longer on the market? And you can take that into consideration. Obviously, they don't want to have people deferring sales, waiting for a new model, but it is something that you should try to consider and think about, just so you know what you're getting into. And then the only thing I think that I would really like to emphasize is that idea that really get input from your field providers when you're making this decision. Look at that user interface, and make sure, that you're picking a device that people feel they can utilize appropriately in those critical situations. And I think that will, allow you to implement that device in a much more successful way.
Well, great. Vince, thanks for being here to help us all better understand what we should be thinking about when we're considering the purchase of a new manual defibrillator. And, very, very helpful tips. So hope everyone will take all that information to heart.